Hello, fellow academic colleagues. First of all, it is a great honor to be invited to participate in the conference. My name is Fujiao. I am from Beijing University of Technology. The topic of my research is Joint Multi-View Feature Network for Automatic Diagnosis of Pneumonia with CT Images. The content of our research is primarily divided into the following four parts: introduction, methods, experiments and results, and conclusion. The first part is the introduction. Pneumonia, particularly viral pneumonia with high transmissibility, poses a threat to human health. The main causes of pneumonia are viruses, bacterial, fungi, and mycoplasma, and the clinical manifestations and imaging characteristics of different types vary. Chest X-ray is limited in detecting lesions, while CT scan provides more detailed cross-sections. An automatic system to assist clinical practice in improving diagnostic accuracy is crucial. Our study proposes a joint multi-view feature network for automatic diagnosis of pneumonia with CT images by extracting global features and finding local regions using an object detection branch on the backbone. By fusing global slices and local regions information, classification results can be obtained for each slice. Finally, a person-level prediction mechanism is designed to simulate the diagnostic process in clinical operations for a full chest CT sequence. In this part, we present our data and provide an overview of the data pre-processing. Our study employed 781 planned chest CT sequences from Beijing D10 Hospital. The CT images were obtained using a spiral scan with a 5 mm interval after inspiratory breath-hold. To focus on long window information, the original CT images were cropped to remove noise while preserving long window contents. The above figure shows the images in chest CT sequence of different pneumonia patients. The three rows show the long images of bacterial, viral patient and healthy person from top to bottom, respectively. In this section, we primarily focus on presenting the framework diagram of our study. The architecture of GMF-NIGHT incorporates several key components. Firstly, it extracts the global features of CT images. Subsequently, a fast RCN branch is employed to detect the top K local lesion regions. The features obtained from these local regions are then fed into a graph attention network to further process the aggregated key features. Two pooling operations are performed. These pooled features are combined with the global features and passed through a dense network for the final image level classification. Finally, based on the results of image classification, the person level prediction is derived. This section introduces our proposed method for mapping image level predictions to person level predictions. It involves two steps. First, we determine if the person is healthy by examining in the image level prediction results of the full CT sequence. If all predictions indicate a healthy condition, the person level prediction for the test sample is classified as healthy. Otherwise, in the second step, we identify if the test sample is from bacterial or viral pneumonia. We exclude the slices with healthy prediction results and calculate the average probabilities for the remaining slices. By comparing the average distribution probabilities of bacterial and viral pneumonia, we select the label corresponding to the largest average value as the person level prediction for the test sample. Next comes the experimental section, where we present the details of our experiments. To meet the hospital's requirements, we designed two classification tasks, discriminating between viral and bacterial infected patients and separating viral patients from bacterial patients and healthy persons. In our experiments, we extracted 4 or 6 relevant lesion regions in each CT image and used five-fold validation to assess the robustness and performance of the model. During each fold, we randomly split the t-site into a ratio of 6:2 for training, validation, and testing. To evaluate the proposed model's performance, we used accuracy, precision, FE score, and recall as the metrics to measure the classification results. In order to better capture the feature differences between different types of pneumonia, as shown in the table above, we selected several well-known convolutional neural network models as the backbone networks and compared their performance on the binary classification task. After comprehensive consideration, we ultimately chose ResNet 50 as the backbone network for extracting global features. Incorporating a faster RCN branch, our proposed model effectively captures the anatomical dependency information of local lesions. Their ablation experiments demonstrate the superiority of our model, GMF-Night, surpassing variations lacking local fusion or the graph attention network model. Comparative evaluations with other 3 models consistently affirm our model's superior performance across multiple metrics. However, the limited training dataset comparison solely viral and bacterial lesions led to occasional misclassifications. To rectify this, we included healthy slices in the training site, resulting in a substantial improvement in overall accuracy. Employing a 3 classification model for image level prediction, incorporating healthy slices samples yielded an impressive 93.69% accuracy and notable enhancements in all performance indicators. The refined confusion metric indicates a reduction to only 7 misclassified samples. For the 3 classification task, we added healthy person samples to the test set while maintaining the existing training process. Our model outperformed other methods as depicted in above table. The confusion matrix reviewed this diagnosis of bacterial patients as viral infections, misclassifications of viral patients as bacterial infections, and the healthy individual misidentified as a patient. To provide explainable diagnostic basis for radiologists, we show the several important slices and their viral maps by gram chem. For viral and bacterial pneumonia, the location of the lesions are different. The lesions of viral pneumonia mainly appears in the subpelvic, while those of bacterial pneumonia are mainly concentrated in the long pericardium. From the figure, we can see that the proposed model has paid more attention to the lesion regions, which can clearly reflect the location information of the lesions. The visualization results are consistent with the clinical diagnosis basis, which further verifies the reliability of our method. The final part is the conclusion. Our study presents a joint multi-view feature network for automatic pneumonia diagnosis using chest CT sequences. By incorporating a faster ascending branch and a graph attention model, they effectively detect focus regions and aggregate features, considering the location relationship and dependency relations of local lesions. The integration of these components has resulted in a 0.65% improvement in accuracy compared to the model that does not consider local features. Our experimental results confirm the feasibility and superiority of our proposed method.